Good afternoon, everyone, and welcome to PoCoG's webinar, Thriving with and Beyond Cancer. My name is Juliette Lum, and I am one of PoCoG's community advisory group members with lived experience as both a cancer patient and a cancer carer. I have the privilege of chairing today's webinar, and it's wonderful to see so many people joining us, not only from Australia, but from around the world. Wherever you're tuning in from and whatever your experience with cancer, thank you for making the time to be here. As you may know, today is World Psycho-Oncology Day, and it's being marked through dozens of events around the world, a powerful reminder of the global commitment to supporting the psychosocial well-being of people affected by cancer. Before we begin, I would like to acknowledge the traditional custodians of the lands on which we meet. I am coming to you from the lands of the Wallumattagal people of the Darug Nation, and I acknowledge the elders past, present and emerging. I extend that respect to any First Nations peoples joining us today and to the Indigenous peoples of the lands you are joining from. So a quick overview of today's format. In a moment, PoCoG's Chair, Professor Haryana Dillon, will introduce the purpose of this webinar. We will then move into a smorgasbord of 7 taster presentations covering a wide range of practical topics for living well during and after cancer. There should be something for everyone. After that, we'll come together to answer your questions. So just a few housekeeping items. This webinar is being recorded, but your face and your name will not be seen. The recording will be shared after the session. If you have a question during the session, there's no need to raise your hand. Just submit your question using the Q&A button, which you can see on the screen. It looks like that. You should be able to find it at the bottom of your Zoom screen. And you can also upvote a question that you'd like answered by clicking on the thumbs up button under that question. And we'll get to as many questions as we can in the Q&A segment. And finally, an important disclaimer. This presentation is for informational purposes only and does not constitute medical advice in any way. Always seek the advice of your physician or other qualified health providers with any questions that you may have regarding your own circumstances. And with that, thank you again for joining us, and I'm delighted to hand over now to Professor Haryana Dillon, PoCoG Chair.
Hi, everyone. Thank you so much for that warm introduction, Juliette. And it's my job just to introduce PoCoG and what we're about so that you can have a bit of context for all of the things that we're talking about today. So I would like to echo Juliette's acknowledgement of the traditional custodians of the lands, and also to point out that PoCoG has been actively working in trying to improve cultural responsiveness in cancer care for Aboriginal and Torres Strait Islander people. And we have a series of e-learning modules on our website that are freely accessible for anyone that might be interested in learning more about that. So psycho-oncology really matters because we know that cancer and its treatments can have significant impacts on people in terms of the difficulties making decisions, symptoms and side effects, so physical declines, emotional changes, lack of social connectivity, cognitive changes, and all of the things that go with that. So our aim is really to try and address those symptoms and side effects and try and help people live full lives after their cancer diagnosis. We do that sometimes through talking therapies like cognitive behavior therapy or acceptance commitment therapy and other things. We also are engaged in behavior change that relates to physical activity and dietary interventions, sometimes art and music therapy, and also social connections, so peer support and those kinds of things that we have evidence for. Aspects of all of these things help different symptoms, and that's what we're going to be talking about today. You've got a great series of people who are going to talk about their experience in this context. I won't go through these in detail, but really just to emphasize that PoCoG's mission is all about developing and facilitating high-quality interventions and services that optimize psychosocial and supportive care. And we do that by supporting people from around the country to come together to develop new research questions, protocols, and make sure that they are fit for purpose for all other people and that they're going to be potentially effective when we evaluate them. That's the end of me, and it's my great pleasure to introduce Dr. Kira Webb, who's a postdoctoral research fellow with us here at PoCoG. And Kira is going to be talking about the work that we're undertaking in supporting the carers of people with cancer. So over to you, Kira.
Thank you, and thank you for the opportunity to present. Today, I'll be talking about how we can support cancer carers through the use of psychosocial resources. Informal carers are the partners, friends, and family members who play a vital role in supporting people who live with and beyond cancer. They provide various types of support from diagnosis through treatment and beyond. However, there are significant demands associated with this role, which can impact on carer quality of life. We find that cancer carers often experience higher levels of distress and burnout, increased experience of depression and anxiety, and high levels of fear and worry about their loved one's cancer coming back or progressing. In the Australian context, there's no standardized psychosocial support for cancer carers, and this is linked to challenges within the health system, including limited capacity, focus on the person receiving care, and challenges identifying those most in need of support. When we look at what support is available, we find that this centers around how to support the person with cancer or how to be a better carer. And what we really need is carer-focused support, which centers the carer and their needs. Here at PoCoG, we have the Carer Recognition, Empowerment and Support Lab, as well as the Carer Special Interest Group, which represents a group effort to improve outcomes for family and friend carers. In the research context, we use different approaches to understand carer experiences and target specific concerns, namely exploratory research, which often uses interviews and is aimed at exploring or understanding experiences, and intervention research, where a resource or program has been developed to provide information or help manage a specific concern. Today, I'll talk about some of the research we're doing here at PoCoG to improve outcomes for those that provide support to people living with cancer. First, an upcoming exploratory study, which we'll be recruiting for shortly. Here, qualitative interviews will be used to explore care experiences in 3 key areas. First, the carer's own health and lifestyle behaviours. So, for example, think sleep, physical activity, alcohol use and smoking, as well as engagement with their GP. Home care tasks, so exploring challenges and experiences providing care in the home, including medication administration, side effect monitoring, and nutrition support. And this will really inform future training and support resources for carers. And finally, in the context of clinical trials, understanding carer support needs when a person they care for is considering or already participating in a cancer trial. Separately, interviews will be conducted with healthcare professionals to better understand how carer support is currently delivered in Australia, including gaps and unmet needs. Now to talk about some of the intervention studies where we are piloting newly developed resources to determine whether they are useful and acceptable. First, Carers Can Access, led by PhD candidate Hannah Isaac. Together with the research team, they developed this online resource for family and friends of people with cancer. To do this, they worked with cancer carers and health professionals to build this resource to meet identified needs. And what this resource does is provide information and practical support to help carers weigh up their options and make decisions about where and how to seek emotional support for themselves. There is currently a pilot study underway, which you can access using the QR code. And what this study aims to understand is whether the resource is useful, helpful, and user-friendly. A second pilot study we are currently conducting is Carers Conquer Fear. And this study is also open to sign-ups at the moment. Here we're looking at a newly developed online program to help carers manage fears and worries about their loved one's cancer coming back or progressing. This program uses what we call a digital storytelling approach and follows 3 carer characters as they visit their psychologist to learn different strategies to manage worry. The aim of this program is not to remove worries, but rather to teach strategies to give the worry less attention. In this program, carers complete 4 lessons over 4 weeks. And in our pilot study, we're hoping to understand whether the program meets the needs of carers experiencing these worries and is easy to use and complete. And to wrap up, a recent randomized controlled trial was used to evaluate online program carers can adapt, reflecting the next step in research after initial pilot studies. Led by Dr. Rebecca Leitzar-Powell, this online program is cancer-specific, using cognitive behavioral therapy to manage anxiety and depression. It includes 6 lessons completed weekly and uses different strategies and activities to give carers the tools to manage anxiety and depression. Like Carers Conquer Fear, it also uses a digital storytelling approach. As part of this trial, the team recruited 300 carers to participate, recently closing off recruitment, and data analysis is underway to evaluate the program effectiveness, a crucial step before a program becomes available. So findings for that coming soon. We know that cancer carers provide critical support to friends and family members living with and beyond cancer. They have unique needs and concerns, which is why we need carer-specific support. We love hearing from carers, community members, and health professionals about how to better support carers, so please reach out if you have any questions or if you're interested in being involved. And thank you to all of the amazing research team and carers that have been involved in this work. Might hand over to our next presenter, Dr. Purva Pradhan, who will be talking about fear of cancer recurrence.
Thanks, Kira. Hi everyone, I'm Purva, and today I'm going to be presenting about fear of cancer recurrence, which involves what it is essentially, what helps, and what's next in the research pipeline. So, finishing cancer treatment is one of the biggest milestones that one can imagine in their cancer journey. But for many survivors, it's also when the real question begins. Now, what's next? And with survivorship rates rising significantly over past 5 years, there's a growing attention to the challenges that survivors face, and fear of cancer recurrence and progression is one of the topmost challenges that people with or beyond cancer reportedly or inconsistently face. And this is essentially defined as worry that cancer could return in the same place or spread elsewhere, which is fear of progression. And it is such common survivorship issue that researchers often call it as a sort of Damocles, which is a constant threat hanging over daily life. And these quotes from survivors of ovarian cancer show how fear of cancer recurrence or progression can feel like a constant background worry, interrupting their day-to-day or their daily life, stopping people from making plans, and makes waiting worry for test results feel unbearable. So, what it essentially looks like and why this is such an important issue. Fear of cancer recurrence or progression varies from mild, which is essentially normal and adaptive in context of cancer diagnosis and treatment, to severe and persistent distress. So, for some, it involves constant symptom checking, for example, pain, seeking constant reassurance, frequent medical visits, poor sleep, difficulty in concentrating, heightened anxiety before scans, often commonly known as scanxiety in the literature. And when this is intense, this fear can significantly reduce the overall quality of life, disrupt daily functioning, and even after treatment ends. And as a result, support for managing these fears is one of the most commonly reported unmet needs in the survivors of cancer. Now, how do we manage? Well, the good news is that the psychological support can effectively manage fear of cancer recurrence and progression with strong evidence for stepped care approaches, and which can be the diagram of which can be seen on top right corner of the slide. This stepped care approaches essentially means matching support to the need, which starts from lower intensity self-help resources for milder worries, constituting to step 1 and step 2 in the figure. Adding a brief clinician or, for example, nurse-led or online support for moderate fear, which is step 3, and then reserving intensive therapies like CONCO-FEAR for severe persistent distress. So this ensures that the resources are used when they are most needed. And Fearless is one such stepped care program which uses screening tools to guide support. People with moderate fear of cancer recurrence in this Fearless program receive a self-guided management booklet, while those with severe fear of cancer recurrence scores are offered conquered fear therapy. The Conquer Fear therapy is delivered in 5 psychologist-led sessions. This program has a strong evidence for reducing fear and anxiety and improving overall quality of life. And this teaches skills such as managing worries, reducing unhelpful checking, mindfulness, and values-based goal setting. And how to access this support? So the manuals and resources are available on PoCoG website, as you can see on the bottom right of the slide. Patients can also be referred to trained psychologists across Australia who can deliver this intervention, and an online version of intervention is currently being tested. So what's next in the research pipeline? From fear of cancer recurrence special interest group perspective. So in scope, which is implementation of stepped care for oncology patients' experience for fear of cancer recurrence, is a proposed trial that will aim to build the evidence base for stepped care approaches to fear of cancer recurrence, and which will test whether integrating stepped care into routine care can effectively identify and treat fear of cancer recurrence. So this trial will compare 2 of the most effective psychological interventions. Firstly, traditional CBT, which challenges the unhelpful thoughts to develop realistic coping skills, versus contemporary CBT like mindfulness or acceptance-based approaches that focuses on accepting difficult thoughts and feelings without reacting, just to see which one works best, and also testing whether stepped care is more effective than usual care. Well, the overall the goal is to create a sustainable model that improves access to fear of cancer recurrence treatment nationally and is cost effective while improving survival's overall quality of life. Thank you so much.
Thank you so much, Purva. That was really amazing and great to see that resource and continued support for survivors and those with cancer. Thank you. Next up, we have Dr. Rachel Campbell, and Rachel is a Senior Research Fellow at the School of Psychology at University of Sydney, and her presentation will be on the management of cancer-related fatigue in people living with a brain tumour. So over to you, Rachel.
Excellent. Thanks so much, Juliet, for that introduction, and thanks everyone for the opportunity to speak today. So just in background, cancer-related fatigue is commonly defined as a distressing, persistent, subjective sense of physical, emotional, and/or cognitive tiredness or exhaustion that's related to cancer and/or cancer treatment, that's not proportional to recent activity, and that interferes with usual functioning. And cancer-related fatigue is the most common symptom that is reported across all tumor types, both during treatment and during survivorship. But as the title alludes, so in the context of this talk, I'm going to focus on cancer-related fatigue in the context of people living with a primary brain tumor. And so around 39 to 77% of people with low-grade gliomas report fatigue, and around 40% continue to report fatigue up to 8 years after finishing treatment. And these prevalence rates are even higher among people with high-grade gliomas, and particularly following a tumor recurrence. And so in a qualitative study that our research group conducted, we found that this fatigue has really diverse impacts on the daily lives of people living with a brain tumor. And so for some, it worsened their brain tumor-related symptoms, so particularly their cognitive difficulties. Others described the psychosocial impacts of fatigue on their mental well-being, as well as on their relationships. So this was often because they simply lacked the energy to spend time with their loved ones, which then led to feelings of strain and tenseness within their relationships. And then others spoke about the real functional impacts of fatigue on their daily lives. So in terms of needing to reduce or to stop work or study, they also talked about simply finding it hard to just carry out their usual everyday activities like doing the grocery shopping or cooking, and also simply finding it really hard to engage in activities that they used to find really enjoyable, like their hobbies or their leisure activities. And so participants in our study, even though this was such a common symptom that's really reported across the board and that it has so many negative impacts on their daily lives, the participants reported that there was a lack of fatigue resources or interventions that were available to them that were really specifically designed for people with a primary brain tumor. So the American Society of Clinical Oncology guidelines that were released in 2024, they recommend evidence-based strategies for fatigue management. And the strategies that they recommend are both exercise and psychosocial therapies, including cognitive behavioral therapy and mindfulness-based programs. And these are recommended to reduce the severity of fatigue both during treatment as well as after treatment into survivorship. But in a systematic review that was conducted by our research group, and it was led by Tom Karlick, we found that there was a real lack of high-quality research examining the effectiveness of these non-pharmacological approaches in people living with a primary brain tumor. This is a really critical gap that needs to be addressed because people with a brain tumor typically experience quite unique cognitive and physical deficits. And so it really raises the question as to whether these approaches that have been found to be effective in people who are living with other cancer types are actually appropriate for this population. And so at PoCoG, we have developed an online program that is specifically designed to help people with a primary brain tumor to better manage their fatigue. And we are currently evaluating this online program in a clinical trial, which is called the REST trial. And we are very excited to announce that this trial just opened to recruitment last week. And so the REST trial is a randomized trial of an intervention to improve self-efficacy to self-manage cancer-related fatigue in people with a primary brain tumor. So who can take part in this study? People who are aged 18 years or older, who have previously been diagnosed with a malignant brain tumor in the past, who are still experiencing fatigue, and who have or are willing to create an email account and have access to the internet. And what will this study involve for the participant? They'll be asked to participate in a brief phone call to assess whether the study is suitable for them. And they'll also be asked to complete an online survey asking for some information about them. Next, they'll be asked to complete an online program, which is made up of 6 sessions, and each session will take them around 30 minutes to complete. And they will have 12 weeks to complete these 6 sessions. They'll also be asked to fill out a brief online survey at 3 different time points throughout the duration of the study. And they'll be asked if they would be willing to participate in an optional interview about their experiences of participating in the study. So if this is something that applies to you and you would be interested in participating, then please follow the link that's shown here on the screen, or you can also scan the QR code. Alternatively, if you are interested in referring people to this study, then please do email the REST trial study team at pocog.brains@sydney.edu.au. And if you're simply interested in learning more about the study, then please visit the REST trial page on the PoCoG website, and you can see the link there at the bottom of the screen. And the study flyer is also available on the PoCoG website, so you can also download that and have a look at that. So yeah, that's it from me, but I'd be really delighted to answer any questions about that later on in the Q&A. Thank you so much.
Wow, thank you, Rachel. That sounds like your research is really filling a niche that I'm sure it's going to impact a lot of people in positive ways. Next up, we have Dr. Maria Furtado, who comes to us from the Peter MacCallum Centre, Cancer Centre in Melbourne, where she's the Director of Psychosocial Oncology. And Maria's presentation today, as you can see, is sleep disturbance in cancer, prevalence, impact, and management. Thank you, Maria.
Thank you to PoCoG for the invitation to present today. I am delighted to be here. Sleep difficulties are very common in cancer. Up to 60% of people with cancer will experience insomnia, and this is 2 to 3 times higher than in the general population. And the sleep difficulties continue and persist post-treatment. Sleep disturbances can be attributed to the physical and psychological impacts of cancer and its treatment. So the physical, the tumour itself, the steroids that people given, the treatment, and the psychological aspects, the worry, the fear of cancer returning, the existential distress, the fear that your sleep is going to somehow also make your cancer come back. Poor sleep has been associated with anxiety, depression, concentration and memory difficulties, lower quality of life, higher rates of pain, and increased use of sleep medications. When we're talking about insomnia, we refer to the difficulties falling asleep, staying asleep, and or early morning awakenings. It has to cause distress or impairment in 3 important areas of life, such as social, educational, occupational, relationships. It occurs at least 3 nights a week for at least 3 months, and the sleep problem occurs despite having adequate opportunities for sleep. Spielman's 3P model indicates that many of us have a number of predisposing factors to sleep difficulties, including things like a family history of sleep difficulties, being female, being older, working shift work. But for sleep problems to really occur, there must be a significant stressor, such as cancer and its treatment. But what maintains these sleep difficulties are the perpetuating factors, what we attribute to and what we do to get a better night's sleep. For example, if you're a bad sleeper, you start developing you go to bed a lot earlier. You put a lot of effort into getting to sleep. If you're feeling tired in the day, you increase your caffeine intake. Then the worry at night that you're not getting enough sleep and you're going to have ongoing difficulties during the day. They all contribute and maintain insomnia and sleep difficulties. Usually when we treat insomnia, the first thing people are often offered is sleep medications. They have some short-term benefits, but there is weak evidence for their long-term effectiveness. The gold standard treatment for insomnia is cognitive behavior therapy. There is strong evidence for it being delivered in groups, individually, in online treatments and self-management. The main problem is that people with cancer and others don't often have access to it. What is usually involved in a CBTI treatment, CBTI aims to challenge or work with the factors that interfere with sleep, the emotions, the behaviours and thoughts that interfere with your sleeps. And it usually involves these components: psychoeducation on how sleep works and normalising insomnia, sleep tracking, sleep hygienes, looking at your diet, exercise and other lifestyle factors, stimulus control, looking at making sure that bed is associated with sleep and not wakefulness, sleep restriction, learning to sort of limit the time in bed to the time that we are asleep, cognitive strategies and reframing our thoughts and beliefs about the consequences of poor sleep, and learning to quieten our mind through relaxation techniques, winding down practices, mindfulness. But for people with cancer, there are other things that need to be added to that, because as we said earlier, a lot of other symptoms interfere with the sleep. issues, such as making sure that we manage pain and nausea and fatigue and the treatment side effects, looking at also adding things in it to manage the anxiety, fear, existential concerns, and taking into account how life and routines are really disrupted, and addressing existential concerns. At Peter Mac, to make CBT sort of more available, we developed what we call the Can Sleep program, and which is a stepped care program. So we assess for sleep difficulties using the insomnia severity scale. If sleep difficulties are experienced, we offer a CBTI self-management with some coaching, and then we rescreen. If people have not improved, we refer them to CBTI with a clinician. We have trialled this sort of model of care in adults with cancer, the AYA cancer population, and also in the ovarian cancer population. And what we usually find is that about 60% of people improve with the self-management and the coaching. And that is about a 1 hour intervention over a 5-week period. And 80% of people will improve with the clinician CBTI. So today we're very excited, and these are our resources that we have produced. So these are the self-management resources. These resources were produced by sleep experts, oncology experts, cancer and experts, and had a number of participants involved. So we've got one for adults. There's a self-management booklet for young people and for people with ovarian cancer. And we have also adapted these booklets into Arabic, simplified Chinese, and Vietnamese. And today we're really excited because we are now launching the Can Sleep Toolkit, which is an online program. You can scan the barcode there, and it has resources for patients and carers, and also for clinicians that have all the resources in that we use in our Can Sleep program for people to deliver in their own institutions or practices. Thank you.
Thank you so much, Maria. It sounds like those resources would be useful for all of us, but particularly for those who are facing cancer. Just a reminder, I know that people are wanting to ask questions along the way, and so please do add your questions to the Q&A. Our hands up function is not working, so you please don't use the hands up. You can just leave your questions in the Q&A, and you can check out the questions that have been asked so far. If there's one that you think, oh yeah, I'd really like to know the answer to that, just put a little thumbs up and it'll make that one go up the list, and we'll try and get to that at the end. So I now have the pleasure of introducing Ms. Emma Minchin, and she comes to us from the University of Sydney, from the School of Psychology, where she's a PhD candidate. She's also a clinical psychologist at the Specialist Menopause Service at Campbelltown, and her presentation is going to be on improving psychosocial care for younger women with treatment-induced menopausal symptoms. Thanks, Emma.
Thank you so much for that warm introduction, Juliet, and it's wonderful that Menopause has a platform here today. I would like to begin just by acknowledging that menopause after cancer may have a significant impact upon people of varying ages and life stages for a number of reasons. However, we know it may be particularly impactful for younger women who experience menopause as a direct result of their cancer treatment, sometimes quite some time before they ever expected to undergo the menopausal transition. And as you may know, menopause or a menopausal state may be induced by certain surgical, chemotherapy, radiation, or endocrine treatments. And alongside often quite intense and long-lasting physical changes, this population may also experience a range of psychological, social, and emotional challenges. However, unfortunately, due to limited research in this area, not too much is known about how we can best support this patient group from a psychosocial perspective. Our research team has been really interested in hopefully contributing to filling this gap. And as part of my PhD research, we've recently conducted a large qualitative study. And this study aimed to really understand, I suppose, or to explore women's experience of induced menopause, particularly focusing upon the psychosocial impacts they may experience, as well as exploring any potential unmet support care needs of women and their partners. And so as part of this, I've interviewed quite a lot actually of younger breast and gynae cancer patients, as well as a range of multidisciplinary healthcare professionals involved in caring for this population. And I'm pleased to be able to share with you just some of the early findings of our research today. In terms of impacts, something I would like to acknowledge first, I suppose, is the highly individual nature of menopause that resonated throughout our study. And this particularly related to people of different cancer types, as well as a number of other factors which informed women's cancer experience or cancer and menopause experience. And I'm happy to speak to those in question time if anyone would like to know more. However, there were a few kind of common themes and impacts that really have stood out throughout our data analysis so far. The first of these was, I suppose, the symptom experience of menopause. And this really spoke to the hormonal changes that women may undergo as a result of induced menopause. And these range from a range of physical symptoms as well as a range of psychological or emotional symptoms. These, importantly, were very much intersecting and interwoven, and participants within our study, both patients and health professionals alike, spoke about, I guess, the intense and quite significant, often, functional and well-being impacts associated with these symptoms. Really interestingly, the impacts from our study, our study suggested that the impacts of menopause don't relate necessarily just to these hormonal changes, but also the act of going through menopause in this way and at this time. And this kind of really shone through in the next few impacts that I'll speak to. The first of these was relational impacts, and really pervasively across our interviews with both clinicians and patients, the significant impacts of menopause upon women's relationships was discussed. And this evolved around kind of impacts to current relationships in terms of sex and intimacy, communication, other relationship difficulties, sometimes even leading to relationship breakdown. Others spoke about some concern or fear regarding the establishment of future relationships, so sex and dating in the future. Others spoke about kind of disruption that may happen in terms of relationships with peers or friends due to going through this experience at a time where others around them just were not. And some of our participants also spoke about some changes in their relationship with their children, which they attributed to induced menopause. Really interestingly, participants in our study also spoke about the way that induced menopause may have an impact upon some women's kind of existential self or identity-related changes. And this kind of theme encompassed a sense of aging before one's time, losing one's youth overnight, or becoming an old lady overnight, as well as shifts in terms of identity, femininity, one's motherhood identity, body image, self-esteem, and also one's occupational and sexual self. And these changes were often accompanied by, I guess, some intense feelings of grief and loss for some women. I think important to mention too is that most clinicians and patients in our study also discuss the highly interrelated nature of menopause and cancer when you're undergoing menopause in the cancer context. I think this quote really captures it so nicely when it was classified almost as a double loss, a double whammy. And many of our participants spoke to the way that potentially experiencing menopause at a younger age in the cancer context may be quite different in terms of both the impacts and also support needs compared to if you're experiencing menopause outside of cancer. In terms of support, it was absolutely not all bad news, but I wanted to highlight a few key gaps for you today. Firstly, really unfortunately, both our patients and clinicians in our study really spoke to the fact that many patients may feel uninformed and really unprepared for induced menopause prior to their commencing treatment. Many patients also spoke to kind of feeling like there weren't appropriate supports for them regarding menopause, particularly supports tailored for their age or life stage. And a real lack of supports specifically targeted partners of patients was also noted. Patient participants in our study also spoke about feeling like they needed to kind of conduct their own research or really rely on their peers in order to navigate menopause care, kind of feeling like they weren't able to access that support necessarily within or from their treating team or other professionals involved in their care. In terms of recommendations, there were many, but I think a few key ones that I'd like to point out were that pervasively, both patients and health professionals in our study really pointed to the need for us to integrate holistic menopause-related support throughout the cancer trajectory, all the way from diagnosis through to survivorship. Psychologists in our study really pointed to, I guess, the need for improved psychological interventions. And here, psychologists also spoke about the perceived inadequacy of current psychological interventions in menopause to really meet the complex care needs of this population. Clinicians across disciplines also spoke to kind of feeling like they needed improved training and support in order to deliver quality menopause care. So to sum all of this up, menopause, both the physical and the psychosocial aspects, really are an important survivorship concern in cancer. And I will note here that that really includes women with metastatic disease. Unfortunately, there are current insufficiencies in menopause support within the cancer context, and I'm really hopeful that we can contribute to improving that. So what's next? As I said, we're hoping our research contributes or sets the stage for starting to improve awareness and understanding of the need for improved psychosocial support for menopause in the cancer context, specifically for younger women, but I think that extrapolates out to women across the lifespan. We are currently working on addressing some challenges to partner engagement, as we'd really like to include some partner voices in our research. And we're really excitedly currently working on some resources and psychological intervention development, targeting directly these patients and partners and their unique care needs. Over time, I would really like to also work on supporting clinicians in the delivery of quality menopause care. So please don't hesitate to reach out to me, and I would like to say a very sincere thank you to our wonderful participants as well as my wider research team. Thank you so much for having me today.
Thank you, Emma. I can certainly relate to a lot of the things that you found in your study, and it sounds like you've identified a big need there that needs to be met. So thank you for the research that you're doing. Next up, we have Ms. Yusra Sert, and Yusra is a PhD candidate in the School of Psychology at the University of Sydney, and her presentation will be on, is called Beyond Survival, Lymphedema in Cancer Survivorship. Over to you, Yusra.
Thanks for the introduction, Juliet, and thanks everyone for joining us today. When we think about cancer recovery, we often focus on survival, but for many people, recovery does not end when the cancer treatment ends. Long-term side effects can continue to affect daily life, and one of these is lymphedema. Lymphedema is a chronic and progressive swelling caused by the dysfunction or damage of the lymphatic system, which leads to fluid building up in the tissues. Lymphedema can be primary, which is a congenital condition, but today I will focus on the secondary lymphedema, which is the most common type, and it's often associated with aggressive cancer treatments, specifically surgery with lymph node removal, radiotherapy, or combined cancer treatments. Lymphedema can affect different body regions depending on the cancer type and treatment modality. For example, arm lymphedema is commonly seen after breast cancer, while lower limb lymphedema is more often seen after gynecological and colorectal cancers. And head and neck lymphedema is also very common after head and neck cancer treatments, and it may affect internal and external structures. So, although it presents differently across cancer groups, its impact can be substantial. Lymphedema is more than just a physical condition. Physically, it causes swelling, tightness, heaviness, skin changes, and sometimes pain. Depending on the location and severity, it can lead to different complications as well. For example, arm lymphedema may result in postural change, while head and neck lymphedema may affect swallowing and speech functions. But also, it has a significant psychosocial effects. Living with a chronic condition and intense self-management may affect emotional well-being, confidence, and overall quality of life. And also physical changes may lead to body image issues, specifically in patients with head and neck lymphedema. Depression, anxiety, and social isolation may result when there is a lack of support. Lymphedema cannot be cured, but it can be managed with appropriate diagnosis and intervention. The stage, location, and severity of the lymphedema, together with the individual circumstances of the patient, altogether will influence the most appropriate intervention, but we also know early diagnosis and effective care are important to minimize the risk of progression. At the clinician level, awareness and knowledge are essential for recognizing risk factors and early symptoms to support timely and effective management. And a comprehensive approach and multidisciplinary collaboration are also important to address physical, functional, and psychosocial needs of people living with lymphedema. At the patient level, engagement is critical because long-term outcomes mostly depend on what happens beyond the clinic. And early and clear patient education about symptom recognition and self-care practices are key parts of the management. Behavioral change and coping strategies are also important in supporting long-term self-management. At the system level, accessible services, structured care pathways, and well-developed guidelines are needed to ensure timely, accessible, and consistent care for everyone. So, what can we do to improve lymphedema care? For clinicians, the message is clear. Be aware of risks and early symptoms, assess patients routinely, and refer promptly, because early recognition can make a real difference to long-term outcomes. And not every cancer clinician needs to be a lymphedema expert, but they should collaborate with a qualified lymphedema therapist. For patients, one of the most important messages is to be aware of early changes and seek help when needed, and feel empowered to play an active role in the management. Just as importantly, they should know they do not have to manage lymphedema alone because support is the most important part of care. For systems and researchers, the message is to create the conditions for better care through clear clinical pathways, better access to lymphedema services, and stronger evidence to guide practice. So overall, improving lymphedema care requires action across the whole care pathway. And effective lymphedema management is not only about reducing the swelling or preventing the progression, it's also building a more responsive and supportive survivorship care system that supports not just survival, but the full experience of survivorship. Thank you.
Yusra, that sounds like a big team effort and all a whole of cycle care. So thank you for the work that you're doing. Finally, so we come to the end of our talks for today. Before question and answer time, we have Ms. Sarah Marvin, who is an accredited exercise physiologist and she's also a PhD candidate at the Sydney School of Health Sciences at the University of Sydney. Her presentation is on the role of exercise during and following cancer treatment. Thanks, Sarah.
Thank you, Juliet, and thank you for inviting me to speak for you today. So we know that physical activity and exercise are often used interchangeably by the general population, but in terms of research, they do actually refer to slightly different things. So physical activity is an umbrella term that encompasses exercise, but it also encompasses things like active transport. So maybe walking from point A to point B rather than driving, housework and gardening, and also occupational activity. So some occupations are inherently more active than others. So when we are talking about exercise, we are talking about something that is planned, structured, repetitive, and purposeful, and also of a sufficient intensity as well. So decreased exercise is very common following a cancer diagnosis. So up to 80% of patients report decreasing their physical activity levels or their exercise levels. And there are a number of reasons for that. So commonly reported barriers to exercise include side effects of treatment, lack of time, and often that is because of medical appointments, but also work and family responsibilities. And also the absence of guidance and support from health professionals. So a recent qualitative analysis that I conducted, so interviewing patients with melanoma undergoing immunotherapy, we've found that it is quite common to not receive guidance related to exercise unless patients actively seek out that information. All of these barriers contribute to a cycle of inactivity. So as a result of these barriers, we see reductions in exercise levels. That leads to an increase in symptom burden and severity, and that in turn causes increased or additional barriers to exercise. And it's quite a vicious cycle that's quite difficult to break. Which is unfortunate because we know that exercise carries a range of benefits for people, both during treatment and following treatment. So across a number of studies, we've seen improvements in physical fitness, muscle mass and strength, physical function, quality of life. There's some suggestions that it can improve treatment completion rates, whilst at the same time reducing cancer-related fatigue, side effects, suppressive symptoms, and rates of progression and recurrence. But as Rachel explained previously in relation to cancer-related fatigue, we know that the evidence for these outcomes is stronger in some cancers and treatment types than in others. Where PoCoG really fits into this is that when we are designing exercise studies, we ensure that we are including patient-reported and psychosocial outcomes in order to evaluate the effectiveness of our exercise interventions, rather than just looking at physical outcome measures. So briefly, what should we aim for? There are a number of guidelines and different resources that you can utilize that will explain an ideal prescription depending on what outcome you're looking for. But the summary is, it's quite complicated. There's no right or wrong answer, and it's not a one-size-fits-all sort of approach. So, like I said, there are general guidelines that exist, but they are in line with what we suggest or recommend for the general population. So, with aerobic exercise, your cardiovascular exercise, it's recommended that we complete 30 minutes of moderate intensity aerobic exercise most days a week. There's different ways that you can quantify that intensity. One way is the talk test. So moderate intensity is an intensity that you could talk and have a conversation with when you're exercising, but you couldn't sing if you were that way inclined. So you wouldn't be able to talk like I am right now. With resistance training or the strength training, 2 strength sessions per week are recommended at a moderate to high intensity, working major muscle groups of the upper and lower body. But I want to emphasize that whilst this may be the goal, it's unlikely that this would be the starting point. So if you are someone that for whatever reason is currently not doing much exercise, you wouldn't jump right into 150 minutes per week. So it is a gradual and a staged approach, and these guidelines may not be appropriate for everyone. So some people who are cachexic, and we're seeing rapid weight loss, rapid loss of muscle mass. Resistance training is very important because it helps to build that muscle mass, but we tend to pull back on our recommendations for the aerobic training because we don't want to do anything that's going to stimulate or has the potential to stimulate increased weight loss. So I guess my overall point that I'm trying to make is that exercise should be individualized for everyone, but particularly for people during treatment and following treatment. And we're starting to see a shift in research in that we are looking at real-world evidence, so evaluating programs that exist in real-world settings, acknowledging that it is often challenging to implement research into practice. And if patients are not sure of what to do, where to start, what's too much, what's not enough, speaking to a qualified professional like an accredited exercise physiologist is always recommended. From the clinician side of things, the most important thing to do is have these conversations around exercise. We know that receipt of exercise education and exercise guidance is known to facilitate increased exercise participation and achievement of exercise guidelines. So just having these conversations around exercise is important, but also considering how these conversations are taking place. So oftentimes health professionals tend to self-report engaging in these conversations at greater rates than patients report receiving that guidance. So perhaps the manner in which these conversations are taking place is not meeting the needs of the individuals. So thinking about having the conversations, how we're having them, factoring in behavior change as well. So turning exercise from something that we know is important and we know that we should do into something that we want to do. And referring patients on to health professionals with specialized knowledge. So again, perhaps exercise physiologists to assist patients in this way. But exercise, like I said, carries a number of benefits. And in a lot of cases, it's just about getting started and ensuring that we do so in a way and we encourage patients to exercise in ways that is feasible and appropriate for them. Thank you.
Thank you so much, Sarah. That was really, really interesting, and thank you for the work that you exercise physiologists do. It's very important work. Thank you to all of our presenters today. We've had quite a lot of really useful information, and hopefully you've been able to take away something from today. We now have a few minutes that we can have a few questions answered. So I know that some questions have already been answered by Harry on the Professor Dillon on the Q&A, but we've also got a few more. And so I'll just hand over to Hariana and she will direct those questions to the speakers.
Great. Thank you so much. And thanks to all the speakers and for all of our participants for really interesting questions. I've answered what I could on the fly. I guess there is a question that I am going to push through to Sarah, actually, about whether or not just even using the word exercise and is a point at which people turn off from engaging with the conversation about getting more active. So do you have any suggestions on how people might be able to have a conversation that will encourage people to be active without kind of, tuning out?
Yeah, very common. I do see it a lot in practice. I think the important thing is that you do, to an extent, need to know what you're talking about when you're providing this education. So if you're sitting there in front of a patient and just rattling off all these guidelines that are not going to be appropriate for the person in front of you, that's just not going to stick at all. And so I think having the knowledge, if you don't have the knowledge, referring on to someone who does, and having resources, if it's pamphlets, things to give to people. But I think as much as we can try and make exercise not so scary. So having that approach of something is better than nothing, having a conversation about what are you currently doing, what do you like doing, what don't you like doing. I think that helps to, I guess, get people kind of interested in exercise. But there's no easy solution. But I think the important thing is that we try, and it will work for some and it won't work for others. But we don't know unless we put the effort into trying.
Right. Thanks so much, Sarah. And I'm going to throw back to Juliet to take us out.
Thank you. And thank you once again to all of our presenters and to Professor Dillon for this webinar. I'm sure that whatever experiences that people have had with cancer, that there was something useful in today's webinar. I personally have taken away quite a few things as a cancer survivor and a carer as well. So just to finish up, you will be getting a survey so we can find out a little bit about what you thought of this webinar and how you heard about it. If you'd like to do it straight away, you can use that QR code with your phone and you can finish this survey in a couple of minutes. That would be really great. And as we wrap up now, I'd also like to remind you that we are going to share the webinar recording with you. So any of the studies that you're interested in following up or participating in, or the QR codes will be shared with you there. So don't worry about that. You will be getting that in your email as well. So thank you again to PoCoG for hosting this seminar, and happy World Psycho-Oncology Day to all of you. Thank you and goodbye.